Hello, everyone. I hope you're having a good day wherever you are in the truly international meeting, and you have audience from across the world for this meeting. I would like to thank you for joining us, and I would like to thank all the speakers who are volunteers and providing the time to provide this webinar to all of us in order to learn from them what they're doing with the rapid diagnostic and biomarkers in clinical practice. And before I start with the speakers, I would like to thank Fee Johnston and ISAC Secretariat for supporting us in organizing this webinar. And please, if you have any questions, please use the chat box to ask your questions. So we have 5 speakers. After each talk, which is about 10 to 12 minutes, we would have a period for Q&A. So without further ado, I would like to introduce our first speaker is Professor Eric Gluck from the US, Professor of Medicine, who is going to talk to us about procalcitonin in COVID-19 patients. Thank you. Eric, over to you.
Such a pleasure and a privilege to be an invited speaker at this wonderful symposium. I want to thank ISAC for the privilege, and without further ado, I'll go on to my remarks. So we are in the middle end of a pandemic, hopefully, dealing with COVID patients, very difficult group of patients to deal with because the presentation is not all that dissimilar from other presentations of patients with ventilatory failure, fever, cough, shortness of breath, pulmonary infiltrates. And because of the variability of symptoms and the time after onset of these patients' presentation, identifying who has COVID, who has other things is very difficult. Patients can present with just COVID. They can present just with community-acquired pneumonia. They can have a combination of the two. And either one of them can actually predispose to the other, making diagnosis very challenging. So we have procalcitonin, a unique biomarker for bacterial sepsis. It has been around for several decades now. We have been using it in our hospital for 15 years to identify bacterial infections. It has a very high sensitivity and specificity for both. Importantly, there are very few other mechanisms inside the cell that will allow the production of procalcitonin, making it highly specific for bacterial infections. And therefore, in this circumstance, where patients may have a viral infection superimposed upon bacterial or vice versa, it becomes a very, very useful biomarker. For those people who have not had a lot of familiarity with procalcitonin, our cells are equipped with receptors on the outside, these toll-like receptors. There's 8 of them outside the cell, 4 inside. The 4 inside the cell are predominantly for identification of viral particles. The ones outside are for bacteria, fungi, parasites, and any other organism that might attack us. The combination of the interaction of the bacterial wall and these receptors helps the cell identify not only the bacteria, but the specific organism that might be attacking us. Once those receptors are stimulated, inflammatory cytokines are released. Some are prepackaged, and those are the ones that give rise to the SIRS symptoms. Others are produced after a period of time because they require involvement with the unraveling of DNA and production of messenger RNA. So here is a cartoon image of what is going on in our cell when we see a bacteria in the periphery of the body. You can see that the toll receptors are in the upper left-hand corner. This bacteria come in contact with that. It sets off a myriad of chemical reactions, the formation of an endosome. Some of this results in the immediate release of cytokines. Others require translocation to the nucleus through a nucleus factor and unraveling of the DNA. Procalcitonin is one of these. It typically responds to both gram-positive and gram-negative bacteria with the production, relying on the formation of messenger RNA and then protein formation in the cells. Here is another depiction showing what would actually be happening during an infection with multiple different pathways being stimulated. The ones would be very specific depending on the bacteria. But in addition, there is also an inflammatory response that occurs in bacterial infections and non-bacterial infections. And in both of these, both the bacterial infections and non-infective stimulation, IL-1B is produced. And that's why clinicians have a difficult time often identifying the difference between SIRS and a bacterial infection, because IL-1 is responsible, along with IL-6, IL-10, and a few other cytokines, for the fever, the chills, the white count elevation, sometimes even the bandemia, the tachycardia, and tachypnea. So it makes it very difficult for us to be able to differentiate between a bacterial infection and just an inflammatory response without more specific testing. And that's where procalcitonin comes in. This is a 116 amino acid protein, which originally was thought to be solely involved in the metabolism of calcium. But over a period of the last 3 decades, it has been identified as a very sensitive and specific marker for bacterial sepsis, probably useful in warning other cells in the neighborhood of an infection that there is an infection nearby. And also, once it gets into the serum, it spreads to the other parts of the body, alerting the body so that a more robust response can take place. You can see from this slide that procalcitonin is actually produced in virtually every single organ in the body, except for the heart. It's never been identified in heart muscle. Only in the thyroid and in the lung can calcitonin be produced, because the enzymes are not activated in the other cells and the other tissues, which makes it a very significant and reliable marker for bacterial sepsis. The kinetics of procalcitonin, along with some of the other cytokines, are depicted here. And what you can see is that there's a slight delay of somewhere between 4 and 6 hours between the onset of a bacterial stimulation of the cell and the actual production, again, because of the reliance on unraveling of the DNA, messenger RNA production, and then protein formation, and then ramping up of the concentration. This is a good news, bad news thing. Typically, a patient with bacterial infection will always have a high PCT eventually, but some of the other cytokines are more evanescent, and they will disappear before you might have a chance to actually interact with the patient. But procalcitonin and other inflammatory mediators like C-reactive protein have this delay, which makes them a little bit more useful for identifying inflammation from bacteria and non-bacterial inflammation in patients. This is just a cartoon image of what I envision the purpose of this system. Basically, we have in the upper left corner the site of infection, and typically most infections are contained, and therefore the cytokines and procalcitonin basically allow the body to deal with a contained infection. But once the infection is containment is lost, then there is a necessary secondary response. IL-1, C-reactive protein, procalcitonin all take place in this, and they recruit other organs. And sadly, during this whole affair, there is bystander injury, so that's where we get our secondary multi-system organ dysfunction associated with severe sepsis. Okay, so we've been dealing with this pandemic now for over a year. The data that I'm going to present to you right now is Swedish hospital's experience with COVID patients in the intensive care unit, which is my home base, over the period of time from March 1st, 2020 to just a few months ago, 2021. We are a community hospital that is a teaching hospital. We have residencies and fellowships. We are what is called in the United States a safety net hospital, meaning that there is a significant portion of the patient in our catchment area that are missing out on significant medical needs. For our patients during this pandemic, it became quite apparent to us initially that we should draw procalcitonin levels on all the patients when they were admitted to the ICU because of the variability in presentation, the variability in the time after the onset of symptoms that the patients had when they presented, made it difficult for us to identify whether the patient just had COVID or whether they had COVID superimposed on a bacterial infection or whether they had a bacterial infection superimposed on COVID. Serial measurements were done on these patients when appropriately. I'll have some data to show you in a couple of seconds. We considered a procalcitonin level of 1.0 to be positive. It turns out that typically in the ICU, we used a level of 0.5 in the past, but to improve the sensitivity and specificity, we needed to increase the level to 1.0 to remove some of those patients who basically did have a bacterial interaction, but were not actually infected to the point of needing antimicrobials for that bacterial interaction. Two procalcitonin levels less than 0.5 taken 24 hours apart were considered indicative of no bacterial infection. So in our intensive care unit for patients with COVID, the average length of stay was almost 14 days with a range of 1 day to 79. The average duration of mechanical ventilation was just under 11 days, also with that same range of 1 day to 79. Every patient who was intubated for COVID received at least one procalcitonin measurement. The number of procalcitonin tests varied from 1 to 47. The median number of procalcitonin tests was 8. The first test was always done on the day of admission. The second test was then done based on clinical suspicion and varied from day 2 to as late as day 22. And these are the data on presentation. Patients who had positive PCT at admission, about 12%. Then by day 14, went up to 55%, significantly higher than our classical patients who are on mechanical ventilation for 2 weeks, where the positivity in procalcitonin is still in the very small percentage of maybe 5 to 10%. After day 14, the number was almost 2/3 of the patients. And you can see as the time went by and the procalcitonin levels become more likely to be positive, the mortality rate increased significantly as well. For the patients who had negative PCTs on admission, 88% of them did, but only 35% of the patients throughout the length of their ICU stay remained PCT negative. But you can also see that there is a very significant mortality rate in the patients who became PCT positive and those who remain PCT negative. And virtually every day, the ones that are asterisks on day of admission and day 7 was statistically significant. Day 14, the trend obviously is significant. You can see the numbers, but that did not reach statistical significance, mostly because the N for that, the number of patients in that area was very small. Was this indicative of COVID, of a bacterial infection? Well, you know, our ability to identify bacterial infections under the best of circumstances is very poor. Our culture positivity rate at Swedish is about 25 to 28%. But we can see a nice correlation. At admission, a negative PCT resulted in a negative culture of about, positive culture rate of only 4.1%. So a negative PCT seemed to predict the absence of bacterial infection at admission and got actually even better at day 7 or later. So a negative PCT, even after admission, actually became more useful than it was at admission. And then you can see that a positive PCT, we were able to get culture positivity about 36% of the time, which was a little bit higher than our usual, which was about 28 to 30%. And at day 7 or later, it went up a little bit more. So we found it to be very useful, and my time is almost up, but I just wanted to show you that we're not the only people who had looked at this. In this study, you can quickly see that patients who were COVID positive were less likely to be PCT positive initially because the viral infection should not stimulate procalcitonin production. There were other people who used it more as a prognosticator And you can see that in patients with moderate disease and severe patients and critical patients on the left panel, the PCT levels correlated with the severity of illness. Most attention to the right panel, the death cases. You can see that towards the end of the patient's stay, when they were dying, they almost invariably died from bacterial infections in this particular study. And then in a meta-analysis, there was a very significant correlation between the discharge rate and PCT levels. When the PCT levels were low, the discharge rate was very good. When the PCT levels were high, the likelihood of death was significantly increased. So I've taken my allotted time. I'd like to leave the rest of my 15 minutes for any questions that anybody might have. Thank you again for inviting me, and thank you for your attention.
Thank you very much, Eric, for that interesting presentation. I have a question, actually. There are two questions. Maybe you could answer them both together. I mean, you chose to use a cutoff of 1 rather than the previously defined 0.5. Was that based on experience or evaluation or validation initially? And the second part to the question, I mean, in our experience in Southampton with PCT for COVID in ICU, it's extremely helpful in the first week or maybe 2 weeks, but after that can be really challenging. What's your experience?
So I'm going to take the last question, the last part first. Our patients often were infected with bacteria and then they got better from the initial therapy. We probably did not completely eradicate the infection, or they got a secondary infection because there was often significant spaces between the first episode of PCT elevation and resolution, and then the second episode, and in several patients, even a third episode. The organisms tend to get more resistant to antimicrobial therapy as time went by. Going back to the first part, it was sort of empirical. We understand that there is a biome in the lung and there's bacteria, and COVID caused a tremendous inflammatory response. And a lot of patients had very transient elevations of procalcitonin to levels of about 0.7, 0.6, and then they went back down in a day or 2 or 3 once the patient was in the intensive care unit, got a little bit of the steroids and the other medications that we're using at the time, and then did not demonstrate any other signs or symptoms of infection. The ones whose levels were above 1 typically remained above 1 and sometimes went even higher than that. And so it was based on an intuitive idea, some observation, and understanding that there are a lot of bacteria in the lungs that could easily be translocated due to the tremendous inflammatory response of the lungs to this very nasty virus.
Thank you. I don't think there are other questions, so I'm grateful once more for your time, and I would like to introduce our next speaker, who is Dr. Stephen Poole from Southampton, who's going to talk about his finding from the SARIPOC trial. The background noise.
Hello. So yeah, thank you very much for inviting me, Cordo and ISAC, to talk. So I'm presenting data from a study that we've done in Southampton called the SARIPOC trial, which has been looking at some novel molecular diagnostics in critically unwell patients with pneumonia. So pneumonia remains a very serious cause of morbidity and mortality worldwide, still ranks very highly across the planet, and that's only got more so with COVID. As Professor Gluck just alluded to, current diagnostics have a lot of limitations. So in our extremely unwell patients, sputum culture, blood culture, and urinary antigen testing only identify a pathogen in about 20 to 40% of patients from other studies. And that doesn't allow us to make good, rapid changes to our antimicrobials in real time. The consequence of that are that we undertreat things that are resistant, and much more frequently, our empirical regimens overtreat things that are sensitive. So in the last 2 or 3 years, molecular tests have been developed, which have a turnaround time in the region of an hour and a half or so, detect a lot more organisms than current diagnostics, with a lot more sensitivity. And they also look for genetic markers of resistance. So the hypothesis for our study was that using these tests near patient in critically unwell patients with pneumonia would allow us to improve our antibiotic stewardship and also hopefully improve our patient outcomes. So we used the FilmArray pneumonia panel. It uses nested PCR to look for 33 different targets, 15 semi-quantitative bacterial targets, viruses, resistance genes, and atypical bacteria. And it's validated for use on BAL and sputum, which includes endotracheal aspirates and undirected mini BALs. So this is the kind of extensive list of targets that the FilmArray looks for. So on the right-hand side are the semi-quantitative bacteria, so things in there that are often colonizers as well. So you can see a good range of Enterobacteriaceae and gram-positives, atypical bacterias, the big 5 carbapenemase genes, MECA-AC, MREJ, big MRSA genes, and one very common ESBL gene, CTXM. The viruses, it was developed and licensed before COVID, so pretty much the only common respiratory virus it doesn't look for is SARS-CoV-2. There's been a lot of papers in the last year or two that have evaluated the diagnostic performance of the pneumonia panel. One of the biggest was published in March this year, 52 labs across Europe, doing over 2,400 samples. And essentially they found that it's a very reliable test. Compared to culture, it had a positive percent agreement of 92.9%. So that's equivalent to a sensitivity, and a negative percent agreement of 96%. And it also found that the pneumonia panel detected a great many more bacteria than standard of care. So we did an open label, pragmatic, randomized control trial. We recruited adults who were currently inpatients in our general intensive care unit, neurological intensive care unit, and respiratory high dependence unit of Southampton Hospital. Southampton's a big NHS tertiary referral centre on the south coast, so we take a very wide range of patients for a lot of specialist secondary care. All of our patients who we enrolled had a working diagnosis of CAP, HAP, or VAP. CAP was the British Thoracic Society definition, and HAP and VAP, the IDSA definitions. Essentially, both are a combination of pulmonary infiltrates, inflammatory response, and a physiological evidence of a pneumonia. We excluded patients who had underlying cystic fibrosis or another condition which was characterized by multi-resistant organisms, or patients who were palliative or expected to be palliative soon. So we randomly allocated patients 50-50. Our intervention group got respiratory samples tested on the FilmArray pneumonia panel up front. We also took a blood sample that we did on a mini Vidas analyzer, pictured on the right, for procalcitonin, and we did a urinary antigen test for pneumococcus. When we had adequate sample, we sent it as well for culture. We then interpreted the results in real time as available, fed them back to the intensive care clinician with stewardship and prescribing advice. And we did follow up procalcitonin day 1, 2, 3, and 5. The control arm just got standard clinical diagnostics, and the investigations were all at the discretion of the managing clinical team. We took 200 patients, and our primary outcome was the proportion of patients who were on results-directed antimicrobials. So that was specifically, we wanted to capture the proportion of patients who were on the narrowest spectrum or optimum spectrum of antimicrobials for a pathogen detected as quickly as possible. So this is our trial profile. I'm aware that I'm fairly tight on time, so I'll skip over that. And our baseline characteristics, which were relatively well matched. We recruited from before COVID until afterwards. So there's about 10 to 15% COVID patients in each arm. A slight predominance of smokers and respiratory disease in the intervention arm, but otherwise very well balanced. And what we found was that in our intervention arm, 80% of people went on to results-directed therapy, which compared to 29% in our control arm. What this equated to was more patients getting de-escalations of therapy, so 42% in the intervention versus 8% in the control arm, and more patients getting escalations of therapy as well in the intervention arm, 9% versus 1%. All of our safety outcomes were non-significant. Mortality similar in both groups. Other respiratory requirements, mechanical ventilation similar. So we found that the Pneumonia Plus panel, as others have reported, did detect a lot of extra organisms. So this pie chart just shows the breakdown of things that were detected. So the blue was a complete concordance between film-array and culture for on-panel organisms. The orange is they were the same, but also the film-array detected additional bacteria. And then the grey is the film-array failed to detect or didn't detect an organism that was detected by culture, the grown on culture. And I should say that from this n equals 175, these samples weren't required to be in tandem, so weren't required to be exactly the same sample, and often weren't taken at exactly the same time from this 175. I've got a separate sub-analyses of those, but I haven't really got time. And what we found of the diagnostic accuracy, as again others have reported, if I can draw you to the bottom and the overall section, the positive % agreement, the sensitivity for on-panel organisms was 91%, and the negative % agreement, the specificity, 96%. So we found it to be an extremely reliable test that was very good at distinguishing what was there and what wasn't. So conclusions of the trial, we found that molecular point of care testing for pneumonia did help us increase the numbers of patients who are getting antibiotics tailored to the results and the prevalent organisms. This meant patients were getting more escalations of therapy, so more broadening of therapy, and also more de-escalations of therapy when compared to standard care. And this happened a lot more quickly. And we didn't find any safety signals, which was reassuring. And we also report a similar level of diagnostic accuracy to those other groups, that the film-array pneumonia panel seems reliable. So I'm aware I'm very short on time. There's a few people I needed to thank, and obviously to all the patients who participated in the trial. But our further results are coming soon. So now, if you've got any questions, I'd be happy to take any.
Thank you very much, Steve. That was a really interesting talk and presentation. I could see at least a couple of questions. One of them, it says, so longer length of stay in the intervention arm. Could you please explain?
I can. So the length of stay, there wasn't a significant increase in the length of stay. So there was a slightly higher absolute difference, but that was not statistically significant. So the 95% confidence intervals for that was between 7.5 days less and 2.5 days more. So it wasn't significant. Yeah. And I think it reflects as well that just the very diverse ICU population, that 1 or 2 patients with a very long length of stay can really skew the results.
Thank you. I have another question. Say treatment seems more pathogen directed with the test, but no change in clinical outcome. So is it worth the test and the cost after all? Would a larger study maybe show clinical improvement?
That's a very good question. And the markers of clinical improvement would be very difficult to demonstrate. I think a larger study would find it difficult to show clinical improvement just because we're talking about such marginal gains with manipulating these antibiotics. I think the biggest benefit of the pneumonia panel from our experience was using fewer antibiotics. So actually the stewardship outcomes are the more kind of salient ones and the ones that would be best demonstrated.
And I have another question. It says, how greatly did you rely on a semi-quantitative result for bacterial targets? In other way, do you know presence of pathogen? Does that mean presence of bacteria? Does that mean they're pathogens? Or could they be just commensal and you are treating them maybe in some cases?
Yeah, that's a very good question. So we definitely found, particularly a couple of organisms, I know others have reported as well, Haemophilus and Staph aureus. When we detected those, particularly Haemophilus at lower levels in someone who's got existing respiratory disease, so this film array groups them into bins, into groups of different quantifications of genetic material. So when we detected Haemophilus at the very lowest of those, we'd take it with a pinch of salt, which is why we built in the clinical interpretation before giving the advice back. I don't think it's enough to give these results directly to the clinician, because I think you need to consider the background around that. And I think certainly a few of the Haemophilus and Staph aureus were commensal.
Commensal. Okay, that's great. And I have another question. We have time for maybe 2 or maybe 3. Another question, say, how did you adjudicate for casualty? Or was every identified pathogen assumed to be important? I think you clarified that.
Do you mean causality? So I think we would err on the side of over-treating. So it's impossible to infer causality, I think, with these very sensitive molecular tests. If you found a credible pathogen in a good concentration, we would have a high degree of confidence in it. For example, if we found a Streptococcus pneumoniae at high concentration in someone with community-acquired pneumonia. Typically, as I say, we'd err on the side of over-treating them, as I think we would with culture as well. So if you found an Enterobacteriaceae there, you would probably over-cover it, assuming it could be a pathogen in the absence of anything else.
Thanks. And the last question, it says, was there a specific cutoff point that had been decided between significant and non-significant of bacterial targets? I think you probably hinted.
Yeah, so the semi-quantification, no, there hasn't. And that's something that is difficult to interpret, really. I mean, we have the same problems with culture, where if you find a Pseudomonas in someone with pre-existing respiratory disease, does it represent pathogen or commensal there? So no, there wasn't. That was where the clinical interpretation came into it, the procalcitonin, the use of other biomarkers.
That's great. Thanks, Steve, for this fascinating talk, and thanks for answering our questions. So I will move to our next speaker, who is Professor Philipp Schutz from Switzerland. So the next speaker is Philipp Schutz from Switzerland, talking about ProADM, mid-regional proadrenomodulin in COVID-19 patients. Thanks.
Well, thank you, Cordo, and it's also my pleasure to present here. And I'd like to shift now from pathogen-directed biomarkers to an inflammatory marker, which we have known for a couple of years in other diseases, sepsis and inflammatory lung disease, proadrenomedulin. And we did a study to see whether proadrenomedulin would be helpful in the risk stratification of patients with COVID. And we've heard quite a lot about COVID already, and I think all of you who have worked with patients, you know that COVID can be a rather mild viral infection, but in some patients it really can become this highly high inflammation disease, which causes pneumonitis and all these severe outcomes in patients. And so COVID and inflammation, I think there is a very close link, and understanding this link maybe with a biomarker would be potentially very helpful in better assessing the risk of the patients. And of course, we have learned also from COVID and from this whole pandemic that risk stratification really is important for this disease. Because for once we do not have enough beds in the hospital, we have to understand which patient actually needs a bed, maybe also an intensive care bed. And also we have learned now that there are several drugs which are helping with the disease, such as tocilizumab, but these drugs may only be appropriate for the highest risk patients and not for all patients, because they do have side effects and also costs. And so having a diagnostic and a prognostic marker, which would tell us early on whether a patient is at risk of progression from COVID to severe COVID pneumonitis, I think this will be helpful also to better use these drugs. So I think there is an unmet clinical need, and we need new treatment biomarkers for risk stratification. And of course, there is a lot of different markers which we could potentially look at. A lot of these markers you see here, and we have focused on ProADM because we have known adrenomedulin, the precursor hormone ProADM, from other diseases. And we know ProADM is a pretty good marker to stratify patients with sepsis and also with other types of lung disease, pneumonia, viral bronchitis, COPD. And we know that adrenomedulin is actually one of the most important vasodilators. It's strongly upregulated during inflammatory and infectious diseases. But adrenomedulin may not be as reliable for measurement because the half-life is quite short. And so the prohormone, ProADM, is much more reliable and may give more stable results for the interpretation in a single patient. And so we have also learned from previous studies, and I think this is a very important paper which has been authored mainly by Cordo and a lot of different co-authors here, which have looked at ProADM for early progression in patients with suspected infection. And so this study has used data from different other trials and studies and actually came up with an optimal threshold of 0.87 for ProADM for risk stratification in patients with infection. And so our idea was actually to look at ProADM in patients with COVID and to validate this cutoff of 0.87 to see whether this cutoff would also help us in the setting of COVID patients. So the study hypothesis was pretty clear. We wanted to see whether ProADM would provide additional information. So we did a prospective study. We had patients with all confirmed COVID, and we measured ProADM on admission, and then after every 2 days to see whether admission levels or also follow-up measures of ProADM would provide us with information about the course of disease. So you see, we were able to include about 90 patients in the study. We had some patients referred from other centers. We had a couple of patients that declined participation. And so we had, for the different time points, we did not have a full set of markers for all the time points, but we had about 90 patients, and we had about 20% of these patients that did not survive their disease. And so this is just the baseline, and you see this is the typical COVID population we have in the hospital. So age is around 60, 70 years. The non-survivors were a bit older, a bit more male. A lot of the patients were polymorbid. We used some experimental drugs in the initial part of the study. And then we also used some steroids in the later part of the study. And so here you see ADM, ProADM at the different time points. So time 0 is admission, and then we had every other day, we had another measurement. And you can see for all the different time points, we actually had an increased levels of ProADM in patients that did not survive their disease. And also for patients needing ICU treatment, levels were significantly increased for the patients with ICU treatment at all the different time points. So here I show you now the Kaplan-Meier curve stratified by this cutoff that was proposed by this by the paper of the group, which I have shown you. And I think the study shows you very nicely that for the patients with an initial ProADM level below this cutoff of 0.87, there was almost a non-risk for mortality. So only one patient actually died after 20 days. And this patient had another hit from COVID. So he initially stabilized, but then became sick again after 2 weeks. However, in the other group, the mortality was about 35%. So the marker really helped us to rule out severe disease and mortality in this using this cutoff. And so here you see the statistical analysis, and then we had significant increase in ProADM, as I have shown you. The area under the curve was 0.78, so it was a pretty strong separation of the two populations. And also we had significant results in univariate and also multivariate regression analysis. So if we would adjust for other prognostic indicators, ProADM still remained a significant prognostic marker. We then also calculated sensitivity and specificity, positive, negative predictive value. And I think the study showed us here that particularly for this cutoff of 0.87, the negative predictive value was 97%. So it really helped us to rule out severe disease and mortality in this patient population. And so potentially, I think the marker could be used if you use it in a pre-test, post-test probability scenario. So if you had a patient and you would say, well, probably clinically his risk is not very high, but still maybe 20%. So you are unsure whether this patient really has a risk or not. So in such a patient, a negative ProADM level will put your post-test risk to about 2 or 3%. So you would from 20% come down to about 2 or 3%, and this would certainly help you and would certainly influence your decision-making regarding site of care, and maybe also regarding use of drugs such as tocilizumab in these patients. So in summary, I think ProADM is an interesting biomarker in COVID patients because it reflects endothelial dysfunction. And this was still a small pilot study, but I think the study still shows that ProADM in this patient population helps us, particularly because it does have a strong rule-out value. The negative predictive value was very strong, and I think it could be helpful in the triage of patients and ruling out a significant part of the population where the risk for progression and eventually mortality seems to be very low. This was independent also of other prognostic factors. And so I think the next step here would really be to do an interventional study to see whether the real-life use of this biomarker in the emergency department really can improve clinical triage and thereby improve resource use, improve costs, and put the resources to the patients which really would need the hospital bed or the expensive drug. And with that, I'd like to close, and I'm also happy to take any questions. Thank you.
Thank you very much, Philipp, as always, for the interesting talk and presentation and data. I have a question here. It says, okay, it's a good prognostic marker. What about predictor of patients requiring non-invasive ventilation to invasive ventilation? Do you have any comments or any experience with regard to that in the intensive care using ProADM?
So, you know, the study was a bit too small to really look into that. We also found it to be helpful just for ICU admission or non-admission. You know, I think in the end, a lot of patients we keep in a hospital, it's the main question is whether they need oxygen or not, right? This is one of the main questions. But still, we do have some patients, maybe younger patients, where oxygen treatment may not be necessary or just low dose, and you could do it at home. But you just feel unsure because it's a young patient and you don't want to miss anything. And so particularly during the first time of the COVID pandemic, I think we had too many patients in the hospital. We kept them, you know, maybe a little bit too long because we were unsure. And so I think the rule out, you know, would maybe help us to be a bit more secure about our decisions in the end.
Thank you. I have a question here. It says, very interesting, thank you. Where, bracket, ED, hospital admission, ICU admission, and or in what disease phase, mild, moderate, severe, were patients recruited and baseline ProADM measurements performed? So it's the time of your inclusion, how soon it was, in admission or halfway or?
Yeah, well, you know, it's just a typical kind of ED population you get. So I would say most patients, you know, they had COVID at home, and first they had maybe a little fever, and once they felt really to get sick, they usually come to the ED. So I would say it's between, you know, 5 and 10 days. We also had some patients that were quite sick when they arrived and needed to go to ICU directly. But I would say it's mid through or you know, a bit more. But of course, it's always a mix in the ED of patients, and it's not a very clear time point.
As you said, I think we need more studies, ideally trials, to prove it, because that would alleviate pressure on ED department, on hospital beds, and maybe sooner triage into ICU. But without proper trial, I think it might be challenging. I just would like to draw attention of the audience that their colleagues from Italy, Emanuela Sozio, and colleagues from Basingstoke in the UK, Nathan Moore, with 10 European centers, they're analyzing retrospectively data among COVID patients. And Philipp, your data is included in those patients. So that's probably would be the largest pool of data. Hopefully it would be available for submission soon. So please watch this space. And the final question says, could you utilize ProADM more in elderly rather than in younger individuals, or does that make a difference? I know your study groups.
So we didn't actually stratify according to age. So, you know, I think it is most helpful in a patient where clinically you're not sure whether he really needs to be admitted, and clinically you would say maybe, you know, he does not need the, you know, the expensive drug, but you know, you still have some worry about the patient. So the one where you are not 100% sure whether you can really send him home. And I think this kind of ambiguity patient, I think there the biomarker can really influence your treatment decision making. But you know, I agree. I think we really need a trial to prove that such a strategy is safe and also helps to improve, you know, the management of these patients overall.
Thank you very much, Philipp. And looking forward to more data and hopefully trials in future. Thank you. Thanks a lot. Our next speaker is Dr. Philipp Kanizsai from Hungary, who's an emergency medicine consultant, and he's going to talk about his experience using QiaSTAT, which is the rapid PCR in the emergency department. Peter, over to you.
So hello everybody, my name is Philipp Kanizsai, and I'm in charge of this emergency department that deals with patients with non-COVID and COVID as well. In this very short presentation, I would like to report our dilemmas and our thoughts with the use of the QiaSTAT rapid PCR system. The first wave in Hungary was, I can say it was insignificant because there was a total lockdown, perfect cooperation with very low mortality at the time when in Bergamo hundreds died. In Hungary, there was only 20, 30 deaths over weeks. So we were quite happy to see that. As patients, people lost patience, and with the new mutations, we saw more hospital admissions during the second wave, with increasing mortality and with increasing admissions. And the third wave last year and at the beginning of this year was rather following the international trends with unexpectedly high mortality. Unfortunately, Hungary is the second worst place to acquire COVID, and you're most likely to have complications and die of COVID. And that was not because we had no ventilators, but we had no real ICU care. There was lack of shortage of staff, ICU staff, and we had to face the British strain, which is quite different than the Wuhan strain. That resulted in a peak in April in Hungary. And that was the time when there was, in March, there was a transient decrease in the emergency room admissions for about 2 weeks. So we didn't really understand what was going on. And then there was a sudden increase of severe non-COVID cases, the admission of severe non-COVID cases. And so we had to differentiate patients. We had to select patients who were having COVID because there were a lot of other problems coming up with respiratory infections, but definitely non-COVID patients they were. So what we did was did a separate ER for the COVID patients, and we introduced a pre-triage, which directed patients between those two emergency rooms. Oops, yeah. So there was a need for this rapid PCR. On one purpose was to confirm or exclude the coronavirus infection in severe cases for ICU admission, or just to spot those patients who have coronavirus who required acute procedures, surgical interventions, cesarean sections, OGDs, and a lot of other interventions, and to confirm or exclude the presence of infection in patients who required special care, like psychiatry admissions, gastrointestinal ward admissions, and cardiac admissions too. Initially, it was not a standalone method. We used a lot of traditional PCR beforehand, but at the point where we had to decide where to admit these patients, then obviously we had to look into the severity of the disease. If these patients were stable, then we just did a traditional PCR. But if the patients were unstable, then we had to perform a rapid PCR and a PCR together to decide where to admit these patients. So in last year, about a year ago, we have received this QiaSTAT analyzer, which is a fully automated machine with no touch technique, required a very short training, just basic maintenance, and it gave a result of a real PCR over 70 minutes. And we received a panel of 22 respiratory parameters. The price for one measurement is still quite high. It's about $220. As you can see it on this screen, this is the panel we received. This was a negative report, and that is the respiratory panel that we put into the machine. We performed 261 measurements between August 2020 and February 2021, and another 365 measurements between June 2021 and August 2021. So the number of measurements have been increasing very sharply. I chose these two periods because I got the most data back on validation, whether the PCR was really positive or really negative from these two time periods. In the first period, in 2020, only suspicious cases were, all the suspicious cases, but highly suspicious cases were tested. Unconfirmed cases were mostly, in those cases, it was mostly decision-making and screening. So as you can see it on this slide, we had quite a few positive results, but what really surprised us was the negative, positive, or false negative results. What we did is we always controlled it with traditional PCR, and that was quite worrisome. So we just decided that we cannot make a decision on one single rapid PCR measurement. We have to wait for the return of the traditional PCR result. So if you have a look at this, based on this very simple figure, we had a sensitivity of 0.6, a specificity of 1, a positive predictive value of 1, and a negative predictive value of 0.92, which doesn't look too bad. But since we had no false positives, then I just tend to ignore these figures. So we needed a solution for the false negatives. Therefore, we introduced an intermediary ICU where patients were kept until the first and the second traditional PCR result came back, which is on the premises of the emergency room, staffed by the emergency room and ICU nurses and doctors. And therefore we lost the clean ICU for emergency patients. Meanwhile, we identified a faulty lot in the panels, so that was really quickly rectified. That could also contribute to the number of false negatives. During the second period, from June to August this year, we detected only one positive case. I must say that the coronavirus seemed to disappear in Hungary from May up to now, which is, the numbers are increasing again. And over that period, there was no false negative, no false positive. And we did single measurements, which we didn't do initially. And these single measurements were just for decision-making, whether the patient can go to the operating room or not, or the patient can have the procedure that they required. Unfortunately, we lost some data for real PCR, therefore these numbers were excluded from the analysis. So all in all, we found this quick PCR quite useful in decision-making. The number of false negatives was somewhat worrisome, obviously, and therefore we had to readjust our plans. Obviously there were some unsuccessful measurements which were due to technical malfunction, either a wrong sampling or just wrong feeding. It's rather expensive, but this really depends on if you take into account everything, ICU care and the chance of infecting others, then probably it pays off. Unfortunately, it is quite a long operating time. The samples were queuing up some periods of time because the 70 minutes is quite long. You get a lot of results, but we didn't need that many. With the single measurements, it was rather exclusive with low pretest probability. And recently, we started to use another quick PCR, which I don't have data with yet, This was the Roche LIAT, measuring only 3 parameters: influenza A, B, and SARS-CoV-2, which is more rapid. It's cheaper, and we will see whether it can replace this kind of quick PCR, or it can work together with it. But definitely we need one. So we'll carry on with the use of rapid PCR systems. Thank you.
Thank you, Peter, for such an interesting presentation. I have a question here, 2 questions, in fact. One of them is, you mentioned you were doing for patients who are relatively ill, you do the rapid PCR, but patients who are relatively stable or not ill, you do the traditional PCR. What happened to them? How do you manage from the infection control point of view? How do you manage? Do they have separate areas to go? Do you have
absolutely? This was a separate ER and separate building where coronavirus patients were treated, and the turnaround time of the traditional PCR was about 16-20 hours. Okay. So if they were not unstable, then we could wait with the PCR. Obviously, they were separated.
So are you aware of any outbreak as a result of that?
Say again, sorry.
Are you aware of any outbreak or cross transmission as a result of that?
No.
No. Okay. And the other question is, you said you didn't have any COVID from June till end of August in Hungary. What are you doing?
I don't know.
Vaccination? I don't know. Or is it...
Honestly, I have no clue. But there were no new cases. We do a very limited number of testing though. But okay, no new cases. We test only about 5,000 per day. So. That's not a big number, but it's increasing now, and the number of hospital admissions is increasing too.
I have a question. It says, what are your plans for the coming winter? You mentioned about rapid PCR for flu A, flu B, and COVID. Do you have concerns, or I don't know what's your population, do you have concerns about RSV and other viruses?
No, actually, with the QiaSTAT, we can detect RSV and another 21 parameters. But since it's most likely that we are going to face influenza with COVID together, then we are pushing things towards the use of the LIAT. Okay, which answers your question of whether if it's influenza or COVID.
Sorry, the LIAT doesn't have RSV.
No.
I can't see no more questions. Peter, thank you very much once more for the talk, and would take us to our last speaker, last but not least, Professor Heiman Wertheim from Nijmegen in the Netherlands, who is going to talk about biomarkers in the community and antibiotic stewardship.
Thank you, Cordo, for the introduction. So I'm happy to talk about something outside the hospital now, after in previous talks also on biomarkers, but not so much on a community setting. And how can we use biomarkers to improve antibiotic use? And here's a nice painting of Nijmegen a couple of centuries ago. It looks differently by now. So inappropriate use of antibiotics in the community. So what's actually causing it? That's generally often that there are no diagnostics in the community. So there's limited lab access, particularly in GP settings, and even more so in a setting like Vietnam, where I will be talking about later on. There's really no access at all, and also often no guidelines. So how can a doctor know, is there an infection or not? And if there's an infection, what is it caused by? And what's the resistance pattern? And if you do know if there's an indication for an antibiotic, then of course, then you run into the question, okay, which antibiotic do you choose and what kind of dosing? And there you need to look for the most optimal bug-drug combination or allergies and so on. But I will be really focusing now on the indication, whether or not to start antibiotics. And I think for antibiotics to start, this whole indication issue there it's really beneficial to have a biomarker test that really can exclude an infection that needs an antibiotic, so a high negative predictive value, rather than having a whole panel of tests that you need to do to see is there potentially a virus or a bacteria. And for a hospital setting, as we've seen before by the presentation of Stephen, in a hospital setting, this could be beneficial, but probably in a community setting, this is really pushing it a bit too far. And again, negative predictive value here will be really important. If you look at the community setting, then most of the antibiotics, 80% or so, are really used for pulmonary infections, and also the bulk of antibiotics in general for human use are in the community setting, and not even talking about agricultural use at the moment. But often for respiratory disease that doesn't need antibiotics at all, and particularly in settings where there's a lot of over-the-counter use of antibiotics. Respiratory disease can have all kinds of reasons, varying from postnasal drip, but of course the viral infections, but asthma, allergies, but also for medication and thinking about acid reflux, smoking, and so on. And then after that, you still have to think about, okay, if there is an infection, what is it caused by? So we do think this is an ideal target syndrome for biomarker testing. And particularly, as I already mentioned, if there is an infection, and this is just a picture of a table from a textbook from, I think, 3 decades ago, from the Baron. There you already see, and you already saw it in the presentation on Stephen Poole earlier on, there's so many different kinds of pathogens, viruses, fungi, bacteria, and then also the resistance patterns. This is really too much to test for in the community. Of course, you can prioritize based on local epidemiology to the most important target or targets that need a certain kind of infection control or a certain kind of isolation or a certain kind of treatment. But all in all, for a community setting, particularly in low resource settings, this is not feasible to test for all this. And therefore, a simple test like a biomarker test would be really beneficial. And then based on local epidemiology and local resistance patterns, you can have sort of a guidance. If there's a reason to think about an infection, what type of etiology are you thinking about empirically, and what type of antibiotic would fit best, and have that in a guideline. So CRP has been used quite a bit already in the Netherlands even. The Netherlands, where I work now, has about the lowest antibiotic consumption in the world, I think. And even there, by work by Jochen Kals, published in the DMJ like 10 years ago, even in our settings, we're able to reduce antibiotics even safely in our low antibiotic use setting. And we wanted to test this. Okay, can you also do it in a setting with low resources and high antibiotic use, particularly for acute respiratory infection, often viral in origin? So we used the Alera system, which gives really a quantitative result. You can do it anywhere. It uses a finger prick, and the result is there within 5 minutes. So we did a training in 10 community health stations. And our study objectives was really, okay, can we do this safely, use this point of care safely for acute respiratory infections in both adults and in children? And we really randomized on the individual level. And we also did a health economic evaluation and looked at, okay, is there any trust in the system as well? So some qualitative work was part of the project as well, but the main objective was really to look at the efficacy in preventing unnecessary antibiotic use. And we had all kinds of cutoffs that we can go into later if people are more interested in it. But for adults, we had different cutoffs than for children. And generally, we use the cutoffs as per guidance of the Alera system and based on other work by others. Then if we randomized 2,000 people, 1,000 kids, 1,000 adults. So this was actually the first quite big study in children as well, because often children are not included in these type of studies. And the main symptoms are really quite simple, straightforward symptoms like cough in 90%, more sputum production, 60%, and runny noses, and quite a few dyspnea, and about 1/3 had fever as well. And then here above, you can see a nice sort of mix of different age categories and male, female, but a bit more females. Then if you look at the immediate prescriptions on day 0, you do see quite a significant drop in the CRP arm, is in the box in red. So from 63% to 43%. Day 14, you see that the prescriptions rise a bit, so people do look for antibiotics later on. But you still see in the long term still a reduction in C-reactive protein arm in antibiotic prescribing. And if you look at, so I already mentioned, we did this in 10 community health stations in Vietnam, in the north of Vietnam. And what you see that there were few stations, and you see on the right side of the dotted line in Bat Choi and in Thanh Xuan, that actually there the compliance was probably very low. And if you ask them, and that's part of the qualitative work, it actually, if you talk to them, they said, well, we have so much stock of antibiotics that we just want to dispense whatever the result. So you really have to think about other ways to remove obstacles like procurement systems to avoid that people feel the push, okay, we have to dispense, otherwise we are not using our stock efficiently. So there are all kinds of different aspects. And if you look at resolution of symptoms, actually quite the same in both arms. So we do things that are safe, and there were no people admitted in the CRP arm in a hospital. So there were no serious adverse events seen, and a resolution of symptoms similar in both arms. If you look at cost effectiveness, so this may be a bit of this is a heat map. This is done by Lubel et al., who worked on our data, which was published 3 years ago. And if you just look at the lower left corner over here, that you have to look at compliance. So the higher the compliance, above 80%, and if the test cost is really low, like below like $1.5, then it becomes more cost effective. So the test has to be cheap. The compliance has to be above 80% at least, which is, I think, quite feasible. Then actually it can be very cost effective in countries like Vietnam, and you can avoid over 1 million unnecessary prescriptions every year in a country like Vietnam. So this can have quite some impact. And CRP is off patent, a cheap test. And so we looked at, okay, how could you use it? So we did another work also with Joel Lubel. I was involved with the Oxford group in Thailand. And look, okay, if you're still in malaria endemic setting, but then low malaria endemicity. And this is just slowly and shortly touching on it. But it's really that if you can combine it with RDTs for malaria, actually you can be very effective in actually managing your patients in an outpatient setting. And even if better tests come along to replace C-reactive protein, actually you already have your logistics and everything is in place and all the people are used to it. And if another test with a finger prick is needed, maybe using myxovirus resistant marker, which has been developed, but these are more expensive. CRP is cheap. Once something more cost effective and more efficient comes along, you could actually over time replace it. So what we think, you should not wait too much anymore. There are some rollout studies now ongoing in Vietnam, and we hope to get some results, but there's a delay now, sponsored by Fine Diagnostics going on. So also, if you talk to the people, they're quite happy with the test. Generally, there's quite a bit of trust, but sometimes they say, well, it's a very quick test. How can it be any good? So that's kind of comments you sometimes get. But all in all, they're quite comfortable with the test. And but there's still, what I said, this financial incentive to dispense the antibiotic stock, as we've seen, for instance, in 2 health stations. And it's very key that your communication skills, and that's also what Jochem Kals always says. He's a GP, did a lot of work on CRP. The communication is really key in adhering both towards the doctor, in training the ones that has to do it, and then communication skills from the doctor or the nurse to the patient, which is quite crucial. And there's a similar kinds of things that we see from other studies from the UK, published in Eurosurveillance last year. You see similar quotes that we've seen, really helps diagnosis and treatment. I like it that you get an informative answer straight away. It was good, immediate feedback. And it really saves issuing antibiotics when not needed. So really things that you really want to achieve, those are the things that you also get back from people using it really in the field. And more studies are really coming out with even including it in all kinds of apps and including other markers. So a lot of studies are coming that really showing that, CRP can be really quite useful, but you need to be compliant and your communication needs to be in order. And now there are also other kinds of markers coming along, IP10, TRIL with tumor necrosis factor related apoptosis inducing ligands, all kinds of other things coming along. So probably better things will come in due time. And in the meantime, still people are working with CRP. So this is a nice study by Butler and his group from Oxford who are looking at COPD exacerbations. Also there, way lower antibiotic use when it's CRP guided. So really quite a simple test, patent-free. So, and that's where I can conclude. So there's a lot of potential here, and it can convert a large proportion of unnecessary antibiotic use in humans, can be applied in low-middle income settings, but you really have to think about, okay, about malaria and other NMSC, but also there, like for dengue, there are other rapid tests that you can combine it with. So you have to be really clever, do some modeling work and see, okay, how can I implement it in our setting? For what do I want to use it? And can I do it safely? And of course, check it first before you do it on a large scale. And as I said, you can combine it with RDTs. And you can look at the paper that we published in the Malaria Journal. It's available and cheap. Once your mechanisms are there, you can roll it out. And if things that are better can come along, you can replace it. And but let's not really wait too long to do something about reducing unnecessary antibiotic use and sort of to slow down the development of antibiotic resistance. And there could be a cost aspect involved, but as I said, CRP can be quite cheap. So if your compliance is high, it's probably achievable, and you slow down resistance. So, but you probably need to think about kind of funding mechanisms if it does come at a cost. So this is where I want to conclude, but thank particularly Dr. Nga, pharmacist at the Oxford unit, who was a PhD student on this project, and now a great postdoc involved in a lot of work on antibiotic use and resistance. So thanks.
Thank you very much, Heiman. Such a fascinating talk, and you kept on time. That was great. One question, I mean, the ISAC's Rapid Diagnostic and Biomarker Working Group published a survey on this just before COVID about how to measure impact of these rapid tests. I know in studies when you have a controlled environment, you could measure impact and you could say, actually, this is great. But outside that environment, in clinical practice, clinical use, how do you measure impact? Do you have any comments for the users? For example, if someone adopts CRP in a remote country, low-income country, how do they measure the impact?
So there's now a study ongoing in Vietnam actually to do it on a provincial level, so to really roll out in many different places the CRP test and see, okay, how does it perform and how's the antibiotic use and what is it? And you don't see increased number of admissions, but you really want to see what's happening in general practice. But you do see once you sort of to roll out a little bit uncontrolled, like you've seen in the UK, that you do see actually a reduction in antibiotics, but not as much as you would see in the trials, particularly because people are not fully aware, are not fully informed, and generally are not as compliant with the system or trusting it as much. So you really have to sort of really have clear guidance and really clear training that should come along, and that is often forgotten, sort of the soft aspects in doing it. So you really have to, once you implement it, you have to really train the people working on it and train their communication skills as well, and not just how to read a test. But that's quite crucial.
Thank you. I have a question here from Arjun Chandna, who says, how do you respond to colleagues who are concerned about the safety of CRP-guided prescribing and say that the trials are not adequately powered to detect adverse events? Sufficiently large trials are probably not feasible. How do we move the conversation forward?
Yeah, I think at some point, you can reduce your antibiotic use, unnecessary antibiotics, by 80%, which has a huge clinical impact, I think. If you do it on a global scale, if you think about it, probably a lot of resistance you're going to avert and actually going to save people in the long term. But you have your direct individual patient right in front of you. So on the population level, I think generally it's probably the good thing to do. But on the individual level, I still think it's because often what you see in low resource settings, there are untrained people who really don't know who can use the WHO guidance, how do I dose, or how do I use the integrated management of childhood illnesses. And so that actually having a biomarker test, and maybe CRP is not the best one, but at least we see for acute respiratory infection, which is often upper respiratory infection, very mild. Generally, it is safe and you can do it. And there's a lot of unnecessary antibiotic use in that area. So I think for mild respiratory disease, you can do it, and I think you can do it safely. If you just for febrile illness, you have to be careful with other types of disease and malaria, and so you probably have to combine it. So I do,
So the clinical context is important. I agree, and this answers the second question. So could you please provide more details about patients who are on anti-inflammatory disease, or probably anti-inflammatory medication, and always have high CRP levels?
Yes, so you have to make sure that you have to have a certain group of patients that you're not going to do it in, and you have to really rely. But if there's a straightforward patient like acute respiratory infection where there's the most unnecessary antibiotic use, I think there you can do it quite safely. And there you probably, the CRP test does better than a nurse or a doctor in a low resource setting. So I think actually it helps, probably also can save people rather than harm people.
I fully agree. I think for all these tests and biomarkers that we have used, just for the audience, clinical context is really, really important. And these are just tools to aid you to make decisions or to make better decisions. So it wouldn't replace a clinician, wouldn't replace a nurse, wouldn't replace a doctor, an intensivist or emergency. So please, when you're trying to introduce, for example, a point of care CRP, you need to have a goal or an idea why you're introducing it, what patient category, as Heiman
webinar we thought was a great success to talk about rapid diagnostics. We need to have impact in patient care, and we discussed both COVID, but also other respiratory disease, and from really the hospital setting all the way down to the community. And we look forward to hear any comments for future webinars. If you have any idea what we should be talking about, ISAC really has a reach out to actually all the continents. So it's a great network to have more engagement with and get feedback. So, and to sort of have experts on board who can, reveal all their information to you through these webinars. So thank you again. And also on behalf of Cordo, who unfortunately has an internet problem, but I'm sure he probably would say the same thing, that it was a great meeting, and thanks to all the speakers for joining. So on behalf of ISAC again, stay safe and enjoy the rest of the day or evening, depending where you are. So thank you.
Thank you for the opportunity. Goodbye.